just for a second, the most complex traffic system in the world? Maybe. I don't know. Tokyo at rush hour? Or the Los Angeles freeway system?
Oh, LA, for sure.
Right. You have millions of cars,
Yeah.
millions of individual units all moving at these high speeds. They're merging, stopping, starting, weaving in and out. It looks chaotic from the sky, but there's a profound, rigorous logic to it.
A synchronized logic.
Exactly. The traffic lights are timed to the millisecond. The lanes are marked. Everyone is following this set of invisible rules that keeps the whole thing moving.
That is the healthy brain. It's organized chaos. It is, frankly, a miracle of synchronization.
It really is. Now, imagine if someone hacked the central computer. Imagine if, all at once, every single traffic light in the city turned green simultaneously. Or imagine if every driver suddenly decided to drive at maximum speed in the exact same direction at the exact same moment.
Total gridlock, a complete system failure.
That is the electrical storm we're talking about today. We're looking at the brain not as, a collection of thoughts or memories, but as a raw electrical grid.
Yeah.
And specifically, what happens when that circuitry misfires?
It's a perfect analogy to start with because it really captures the violence of the event. We are doing a deep dive today into Chapter 53, Epilepsy. And the sources we have are fantastic. They go way beyond just the surface level. We're going to look at the physics of the brain, the chemistry of the drugs, and the reality of living with this internal storm.
And our mission is pretty specific, right? We want to strip away the Hollywood version of this.
Yeah.
I think most people, when they hear seizure, they picture one very specific thing. Someone dropping to the floor and shaking.
The grand mal. That's the classic dramatic image.
Right. But as we've learned from these articles, that's just, it's just the tip of the iceberg. The reality is far more subtle, far more complex, and frankly, a lot more interesting from a medical detective standpoint. We have to talk about the terrifying pathophysiology, what is actually happening to the neurons, and the incredibly high stakes game of treating it.
And the treatment, that's where it gets really, really complicated. We're going to talk about a pharmacological toolkit that is, well, it's as dangerous as it is effective. These aren't just aspirin. These are drugs that rewrite your body's chemistry.
Okay, so before we get into the heavy chemistry, we need to lay some ground rules. I was surprised to learn right off the bat that seizure and epilepsy aren't synonyms. I've definitely used them interchangeably.
And you're not alone in that, but in neurology, the distinction is everything. A seizure is an event. It's a transient occurrence. It's the traffic lights all turning green for a minute. It's a symptom, of excessive discharge of cortical neurons.
So a seizure is the explosion.
Correct. Epilepsy, however, is the condition. It's the chronic disease of the brain that predisposes you to having those explosions. The medical definition is actually quite rigid on this.
Which is?
You need to have at least 2 unprovoked seizures separated by at least 24 hours to be diagnosed with epilepsy.
I want to double click on that word, unprovoked. That seems to be the linchpin here.
It is. It's everything. Think about it this way. If I hit you in the head with a baseball bat, or if I shock you with high voltage, or if your blood sugar drops to near 0, you might have a seizure.
Sure. My brain is under attack.
Your brain is reacting to a massive, immediate physical stress. That is a provoked seizure.
So if I go on a huge drinking bender and then quit cold turkey and have a seizure from withdrawal, that's not epilepsy.
Likely not. No, that's a physiological reaction to the withdrawal of alcohol, which acts as a depressant. Once we fix the underlying alcohol issue, the seizures stop. You don't have chronic rewiring of the brain. Epilepsy implies something intrinsic.
Something is wrong with the wiring itself.
Exactly. It means the brain has a tendency to short-circuit on its own without an immediate, reversible, external trigger.
That's a crucial distinction. So if we've established that epilepsy is this intrinsic proneness to electrical storms, we have to ask, what causes the storm? This brings us to section 1 of our dive, the internal storm, or the pathophysiology.
This is where we get into the break and gas theory of the brain.
I love this concept because I usually just think of the brain as firing. I want to move my arm, my brain fires a signal. I want to remember something, my brain fires a signal. But the sources point out that stopping the signal is just as important.
Arguably more important. To maintain order, your brain is constantly, and I mean constantly, balancing excitation, the gas pedal, and inhibition, the brake pedal.
Yep.
The primary gas pedal is a neurotransmitter called glutamate. When glutamate is released, it tells the next neuron, go, fire, pass it on.
And the brake.
The brake is GABA, Gamma-aminobutyric acid. When GABA binds to a neuron, it tells it to just chill out. It opens channels that make the neuron harder to fire. It stops the signal from spreading.
So in a healthy brain, I have a thought. Glutamate fires, the signal travels where it needs to go, and then GABA clamps down on the surrounding areas to make sure the signal doesn't, leak out to the whole brain.
Precisely. It's a process called surround inhibition. It keeps the signal focused. But in a seizure, that balance just collapses. Either you have way too much gas excessive excitation via glutamate, or, and this is often the case, your brakes fail.
The GABA system breaks down.
It breaks down, and once the brakes fail...
The signal spreads like wildfire.
Exactly. It recruits more and more neurons into this synchronous rhythmic firing. Instead of a complex conversation between neurons, you get everyone screaming the same syllable at the exact same time.
The sources mention that this isn't just about the neurotransmitters, though. It goes down to the atomic level. We're talking about ion channels.
We are. The neuron's ability to fire is all controlled by the flow of ions. Sodium, potassium, calcium, in and out of the cell membrane through these little gates. In epilepsy, you often find channelopathies.
Which are just defects in those gates.
Right. Defects in the gates that control the flow of these ions.
So the gate is rusty, or it stays open too long.
That's a great way to think about it. If the sodium channel, which usually drives the firing, opens too easily or stays open too long, the neuron becomes hyper-excitable. It's like a hair trigger on a gun. It doesn't take much to set it off.
And the scary part mentioned in the text is the stakes of this. It's not just that you have a seizure and then you're fine. The storm itself does damage.
This is the concept of excitotoxicity, and it is scary. When neurons are forced to fire that rapidly for that long, they get flooded with calcium. And that influx of calcium can actually trigger cell death.
So the seizure can actually kill brain cells.
Yes. And even if it doesn't kill them, it can rewire them. It can alter the circuitry in a way that makes future seizures more likely. It's a vicious cycle.
Wow.
The more seizures you have, the more, let's say, pro-seizure your brain becomes.
Which is why the wait-and-see approach isn't always the best option. We need to stop the rewiring. That really raises the stakes for treatment. But before we treat it, we have to identify it. Let's move to section 2, clinical presentation. Because as we said, it's not always the dramatic flailing.
Not at all.
The spectrum of symptoms is huge.
It is vast, and it depends entirely on where in the brain the brakes fail.
This is the focal versus generalized distinction.
Right. Think of it as a brush fire versus a forest fire. A focal, or partial seizure, starts in one specific spot, one hemisphere, usually a small area of the cortex. The symptoms you see then reflect the function of that specific area.
So if the fire starts in the part of my brain that controls my right thumb,
your right thumb will start twitching. Just rhythmic, uncontrollable twitching. It might spread up your arm. We call that a Jacksonian march, but it starts locally.
And if it starts in the visual cortex,
you might see flashing lights or zigzag lines or even complex hallucinations.
And I'm awake for this.
In a simple partial seizure, yes, you are fully conscious. You're sitting there, maybe holding a coffee, watching your thumb twitch or seeing these lights, knowing it's happening, but being completely unable to stop it.
That sounds terrifying in a very different way than passing out. It's like being a passenger in your own body.
It is. But if that electrical fire spreads just a little bit more, and it affects the areas of the brain that control consciousness and awareness, then it becomes a complex partial seizure.
Complex meaning I black out.
Not necessarily a lights-out blackout. It's more of an impairment of consciousness. You might just stare blankly. You stop responding to questions. And this is where we see automatisms.
Oh, automatisms. I found this fascinating. These are like glitches in the software.
That's a great way to put it. The conscious mind is offline, but the motor programs are still running on a loop. You might see lip smacking, chewing motions, picking at clothes.
Buttoning and unbuttoning a shirt.
Exactly. And the person has no idea they're doing it.
None.
None whatsoever. And afterward, they usually have amnesia for the event. They sort of wake up and wonder why their shirt is unbuttoned or why everyone is staring at them.
Now, we have to talk about the aura, because I always thought an aura was just a warning sign, like a spidey sense. Oh, I feel funny. A seizure is coming.
Yeah.
But the source material corrects this misconception pretty aggressively.
It does. And this is a major teaching point for medical students. An aura is a seizure.
Wait, walk us through that.
An aura, that feeling of déjà vu or that rising nausea in your stomach, which we call an epigastric rising sensation, or smelling burning rubber when there's nothing there, that is the experience of a simple partial seizure.
So it's the electricity misfiring. in a small, contained area.
Precisely. So if you smell burning rubber, that's your olfactory cortex having a mini seizure.
Okay.
Now, if the seizure stays there and then stops, you just say, I had an aura. But often, that focal seizure serves as the match that lights the fuse. It spreads to the rest of the brain, and then you have the big convulsion.
So when people say, I had an aura before my seizure, they really mean I had a focal seizure that secondarily generalized into a big seizure.
10 points for you. That is exactly it. It's the brush fire, jumping the fire break and consuming the whole forest.
Okay, let's talk about the forest fire then. The generalized seizures. This is when the electricity hits both hemispheres at once.
Or it spreads so fast it seems simultaneous. The most famous, of course, is the generalized tonic-clonic seizure. We used to call it grand mal, which is French for great sickness.
The terminology has shifted, though. Tonic-clonic is much more descriptive.
It is. It describes the two phases. The tonic phase comes first. Every muscle in the body contracts at once. The patient goes rigid as a board. They often let out a cry, the ictal cry, because the chest muscles contract and force air over the vocal cords. And
They fall.
they fall to the ground. And then comes the clonic phase.
That's the jerking.
That's the rhythmic jerking. The brain is trying to inhibit the signal, fighting back, creating this on-off pattern of muscle firing.
And the aftermath. The postictal state.
The brain is just exhausted. It has run a marathon in 2 minutes. The patient is usually unarousable at first, then very confused. They might sleep for hours. And you often see physical evidence like tongue biting, usually the side of the tongue, or urinary incontinence. It's a traumatic event for the body.
On the complete opposite end of the spectrum, we have a type of generalized seizure that is so subtle it can get missed for years. The absence seizure.
Oh, these are fascinating. They used to be called petit mal. They happen mostly in kids. The child they just go offline.
Like a buffering video.
Exactly. They'll stop talking mid-sentence. They'll stare blankly into space, maybe a little fluttering of the eyelids. It lasts for 5-10 seconds. And then snap, they are right back.
And they don't fall. They don't convulse.
No, they don't lose muscle tone. They just lose consciousness. And unlike the big tonic-clonic seizures, there is no postictal confusion. They'll pick up the sentence right where they left off.
So a teacher just thinks the kid is daydreaming.
All the time. We see kids who are failing school because they're missing 20 minutes of instruction every hour in these little 10-second chunks. But the EEG for this is unmistakable. It has a 3 Hz spike and wave pattern. It's iconic in neurology.
It's amazing that blanking out and violent convulsing are technically the same category of electrical storm, just manifesting differently. It really shows the diversity of the brain's wiring.
It really does.
Which leads us to the detective work. Section 3. Diagnosing this seems incredibly tricky because, unlike a broken leg, the problem isn't usually visible when the patient walks into the doctor's office.
That is the fundamental problem. The interictal exam. The exam between seizures is often completely normal. You look fine, your reflexes are fine, you can walk a straight line, the doctor has no clues.
So the doctor has to rely on the story.
The history is paramount, absolutely critical, and not just from the patient. Because remember, the patient might be unconscious or amnesic during the event. You need the witness.
The spouse, the parent.
Right. You need to know, did their eyes roll up? Did they turn their head to one side? Did they bite their tongue? How long did it last? Exactly. All those details are clues.
And there's a really clever lab test mentioned in the notes, something I hadn't heard of before. Prolactin.
Ah, yes. Prolactin is a hormone usually associated with lactation, but it's stored in the brain. During a violent electrical storm like a generalized tonic-clonic or a complex partial seizure, the brain just dumps prolactin into the bloodstream.
So you can use it as a kind of truth serum.
In a way. If a patient comes into the ER and you aren't sure if they had a real epileptic seizure or a pseudo-seizure, which is a psychogenic non-epileptic event that looks like a seizure but isn't, you can draw their blood.
And if the prolactin is high?
If the prolactin is sky high, it tells you, yes, this was a physiological electrical event.
But you have to do it fast, right?
Very fast. The level drops back to normal in about 20 minutes, so it's a right now test. And it's
Right
not
here.
perfect fainting or syncope, can sometimes bump it a little, but it's a great tool to have.
What about the technology, the EEG? Everyone knows the image of the patient with the wires glued to their head, but the source material dropped a statistic that frankly blew my mind.
Let me guess. The 50% one.
Yeah. Epileptiform activity is found in only 50% of patients with epilepsy.
It is a humbling stat. It means you can have epilepsy, severe epilepsy, and have a perfectly normal EEG on the day of the test.
That seems So counterintuitive.
Well, think of it like fishing. You're trying to catch a fish, which is the seizure spike, in a vast lake, which is the brain. If you only drop your line in for 30 minutes, which is a standard EEG, you might just miss the fish.
So the fish are there, they just aren't biting right now.
Exactly. So a normal EEG proves nothing.
A normal EEG does not rule out epilepsy.
Correct. However, we do have tricks to increase the yield. We might sleep deprive the patient, for example.
Sleep deprivation triggers seizures.
It stresses the brain. It lowers the seizure threshold. A sleep-deprived brain is a grumpy, glitchy brain. So we tell them to stay up all night and we hook them up to the wires. It makes it much more likely we'll catch that spark.
That is diabolical and clever. It really is necessary detective work, though. We also need to mention the big imaging machines, MRI versus CT.
Right. So the CT scan is the quick look. In the ER, you do a CT to make sure there isn't a brain bleed or a massive tumor causing the seizure. It's fast and available, but the MRI is the gold standard for epilepsy.
Because of the detail.
It gives you incredible detail. We're looking for tiny scars or sclerosis, particularly in the temporal lobes, which are a real hotspot for focal seizures.
Okay, so we've diagnosed it. We know the patient has epilepsy. Now we have to treat it. Section 4, the strategy. And the sources emphasize that the goal isn't just 0 seizures.
No, not at all.
It's 0 seizures without turning the patient into a zombie.
That is the quality of life equation. If I give you enough phenobarbital to stop an elephant, your seizures will stop. But you will also be asleep 18 hours a day. You won't be able to hold a job, drive a car, or have a conversation. Have I really treated you?
No. So where do you start?
The mantra is start low, go slow.
Yeah.
We pick one drug, what we call monotherapy, and we titrate it up slowly. And the data is actually pretty encouraging. About 65% of patients can be controlled on just one medication.
That's better than I expected. But there's a big but coming.
The but is human behavior. The source notes that up to 60% of patients are non-compliant. They don't take their meds.
60%. That is a massive failure rate. Why?
It is the most common cause of breakthrough seizures. And we have to be empathetic here. These aren't like antibiotics you take for 10 days. These are drugs you take twice a day, every day, potentially for the rest of your life. And as we are about to see, the side effects are not trivial.
Speaking of the rest of your life,
Yeah.
is it a life sentence? Can you ever stop the medication?
You can. It's not a permanent sentence for everyone. The guidelines suggest that if a patient has been seizure-free for 2 to 4 years, has a normal EEG, and their epilepsy started in childhood or early adulthood, we might try to wean them off.
But it's risky.
It's a calculated risk.
Right.
If you have a history of status epilepticus, that's the nonstop, life-threatening seizure, or if you have other neurological problems, the risk of recurrence is higher. But for many, getting off the meds is a huge quality of life goal.
And that leads us perfectly into Section 5, the pharmacological toolkit. We have a lot of drugs to cover, and I want to treat them like characters because they each seem to have a distinct personality.
That is a great way to frame it.
Some are reliable old workhorses, some are high-maintenance divas, and some are dangerous specialists.
The personalities of antiepileptic drugs, or AEDs, are very distinct. And remember, they all broadly work by either blocking those excitatory ion channels we talked about, sodium and calcium, or by boosting that inhibitory GABA system.
Let's start with the high-maintenance diva, phenytoin. This drug seems like a nightmare to manage.
Phenytoin, or Dilantin, is a classic, but yes, it is tricky. The reason is something called zero-order kinetics.
Okay, explain that to me like I'm 5.
Okay, most drugs have first-order kinetics. Imagine a bathtub with a drain. The more water you pour in, which is the drug dose, the faster it drains out, which is liver metabolism. It balances itself.
Makes sense. Double the dose, double the blood level.
Exactly. It's linear, predictable. Phenytoin is different. It's like a bathtub with a tiny fixed-size drain. Once the water level reaches the top of the drain can't go any faster. It's maxed out. So if you add just a little bit more water, the tub instantly overflows.
So a tiny increase in the pill dose causes a massive spike in the blood level.
Exactly. The liver enzymes get saturated. You can go from a therapeutic level to a toxic level with a very small dose increase. It requires constant blood monitoring.
And the toxicity isn't subtle. The side effects listed here are, well, they're physical.
Very physical. Long-term use causes gingival hyperplasia.
Gum overgrowth.
Yes. The connective tissue of the gums literally grows over the teeth. It can be disfiguring. It also causes hirsutism, excessive hair growth in places you don't want it,
Yeah.
and a coarsening of facial features.
So it stops your seizures, but it changes your face.
Yeah.
I can see why a teenage girl might decide to skip this medication from time to time.
Precisely. Compliance isn't just about memory, it's about vanity and self-image.
Next up, let's talk about carbamazepine. This one has a weird quirk, too. It's an autoinducer.
This is fascinating biochemistry. When you start taking carbamazepine, your liver sees it as a foreign invader. So the drug actually stimulates the liver to build more of the machinery to destroy it.
So the drug teaches the body how to destroy the drug.
Yes, it induces its own metabolism. So you start a patient on a dose, it works great for 2 weeks, but by week 3, the liver has ramped up production of enzymes, the drug levels plummet, and the seizures come back.
So you have to anticipate this.
You have to anticipate it and increase the dose after the first month. It's a moving target.
And there's a genetic warning here, too, a very serious one for patients of Asian descent.
This is a triumph of pharmacogenomics. We now know that patients with a specific genetic marker, HLA-B1FIMO2, which is common in Southeast Asian populations, are at extreme risk if they take carbamazepine.
Risk of what?
Stevens-Johnson syndrome, SJS. It is a horrific, life-threatening skin reaction where the skin literally blisters and sloughs off. It's like a severe burn from the inside out.
That is terrifying. So the takeaway is you have to screen for the gene.
Absolutely. It's standard of care now. You must screen.
Let's move to the heavy hitter. Valproic acid. This seems to be the Swiss Army knife of epilepsy drugs.
It is very broad spectrum. It works for generalized seizures, focal seizures, absent seizures. It does it all. It boosts GABA and blocks sodium channels. It's often the first line for mixed seizure disorders.
But every Swiss Army knife has a sharp edge.
And valproic acid has significant baggage. Weight gain is very common, tremors. And unlike phenytoin, which grows hair, valproic acid can cause alopecia hair loss.
And the liver again.
Hepatotoxicity. It can cause fulminant liver failure, especially in young children. It's rare, but it's fatal. It forces doctors to monitor liver function tests religiously.
We also have the sniper, ethosuximide.
The specialist. We use this almost exclusively for those absent seizures in kids we talked about. It targets a very specific calcium channel, a T-type channel, in the thalamus. It's useless for a big convulsion, but it's perfect for the staring spells.
And then the last resort, vigabatrin. The source material basically says, don't use this unless you absolutely have to. Why?
Because it causes permanent blindness.
Blindness.
Bilateral concentric visual field constriction. It's tunnel vision. And once that vision is gone, it doesn't come back even if you stop the drug.
So why would anyone ever take it?
Because the alternative is worse. We use it for something called infantile spasms, a catastrophic type of epilepsy in babies that can destroy their development. You're trading their peripheral vision for their brain function. It's a desperate trade.
That really puts the severity of this condition in perspective.
Yeah.
Let's touch on one more group, the newer drugs, topiramate and lamotrigine. They seem cleaner, but they have their own issues.
Topiramate is a great drug, but we call it Dopamax in the hospital.
Dopamax, as in dopey.
Yes. It causes cognitive slowing. The most specific complaint is word-finding difficulty. You know what you want to say, but the word is just locked away. It's incredibly frustrating for articulate people. It can also cause kidney stones.
And lamotrigine.
Lamotrigine is the tortoise. It's an excellent drug. It's even mood stabilizing. But you have to titrate it incredibly slowly. If you rush the dose, you risk that Stevens-Johnson rash again. It can take weeks to get to a therapeutic dose, so it's not for emergencies.
It's amazing how much strategy is involved. It's a game of 3D chess between the neurons, the liver, and the side effects. And this game gets infinitely harder when you introduce a second patient into the mix, a baby. Section 6, women in pregnancy.
This is one of the most difficult areas in neurology. Epilepsy in women is uniquely influenced by hormones. We know that estrogen is pro-seizure, it excites the brain, and progesterone is anti-seizure, it calms the brain.
So a woman's natural cycle can affect her epilepsy.
Hugely. We even have a term for it, catamenial epilepsy, for seizures that cluster around ovulation or menstruation when these hormone ratios shift. It can be very predictable for some women.
But when a woman gets pregnant, the hormones go crazy. So what happens to the seizures?
It's a roll of the dice. The rule of thumb is the rule of thirds. 1/3 of women will have more seizures during pregnancy. 1/3 will have fewer. And 1/3 will stay the same.
But the real anxiety isn't just the seizures, it's the drugs. We just spent 10 minutes talking about how toxic these chemicals are. Now you're feeding them to a developing fetus.
That is the dilemma. All AEDs cross the placenta, and they are teratogenic. They can cause birth defects.
The numbers in the source are worrying.
They are. The risk of major malformations is 4–6% for women on AEDs. That's double the risk of the general population.
And valproic acid, our heavy hitter, is the villain here again.
It is the worst offender by far.
Right.
It causes neural tube defects like spina bifida, and studies now show it can lead to lower IQ and verbal abilities in the child later in life. We try incredibly hard to get women off valproic acid before they conceive.
But you can't just stop the meds because a seizure during pregnancy is also bad for the baby.
A generalized tonic-clonic seizure during pregnancy is dangerous. It causes hypoxia, a lack of oxygen for the fetus. It can cause trauma if the mother falls. So we're walking this tightrope.
Wow.
We need to control the mother's seizures to protect the baby, but the drugs we use to control them might hurt the baby.
So what's the strategy?
Folate. High-dose folic acid. We start it months before conception. It helps protect the neural tube, and we try to use the safest drug at the lowest effective dose.
There's also a note here about contraception. This feels like a cruel joke of biology.
It is. The enzyme-inducing drugs we talked about, carbamazepine, phenytoin, they rev up the liver, and guess what else the liver breaks down?
Birth control pills.
Birth control pills. So the seizure meds can literally eat up the birth control pills before they have a chance to work.
So a woman on these meds might think she is protected, but the failure rate is high.
It's very high. We have to counsel them to use higher doses of oral contraceptives, or better yet, use non-hormonal methods.
It's such a heavy burden for a patient to carry. Which brings us to our final section, the price of control. We've talked about the acute side effects, the rash, the bums. But what about the long game? If I take these drugs for 20 years, what happens?
There are chronic costs. Bone health is a major one. The older drugs, phenytoin, carbamazepine, valproic, they induce liver enzymes that just chew up vitamin D.
So, osteoporosis.
Yes. You can have a patient in their 40s with the bone density of an 80-year-old. Fractures are a real risk. We often have to supplement with calcium and vitamin D aggressively.
And the mental health aspect. There's an FDA warning on all these drugs about suicide.
There is. It's controversial because epilepsy itself is associated with depression, so it's hard to tease out cause and effect. But we know these drugs alter neurochemistry. Some, like levetiracetam, which is Keppra, are famous for causing irritability. We call it Keppra rage.
Keppra rage?
Yeah, patients just feel angry, short fuse, aggressive. It's a chemical change.
And the cognitive impact we mentioned with topiramate isn't unique to that drug.
No. Phenobarbital, one of our oldest drugs, causes significant sedation and intellectual blunting. It slows down your processing speed. Imagine trying to get through high school or hold down a complex job while feeling like you are moving through molasses.
It really circles back to that quality of life question. It seems like the definition of success in epilepsy isn't as simple as a clean EEG.
Not at all. A patient who is seizure-free but is depressed, osteoporotic, and can't find their words. That is not a success. We have to treat the whole person, not just the electrical tracing on a piece of paper.
This deep dive has really changed my perspective. We started with the idea of a traffic grid going haywire. But managing it isn't just about fixing the traffic lights. It's about managing the entire city ecosystem, the roads, the power, the people living there.
That's a beautiful way to sum it up. It is a condition of immense complexity. It requires a true partnership between the patient and the doctor to navigate that minefield of side effects versus control.
So here's my final thought for the listener. We often use the word compliance in medicine, and it sounds so judgmental. The patient is non-compliant, like they're being naughty or failing a test.
It does imply failure on their part.
But after hearing about the gum overgrowth, the hair loss, the bone loss, the cognitive slowing, the mood changes, I think we need to rethink that word. If you were standing in that patient's shoes, facing a choice between the terror of a seizure and the slow grinding erosion of your personality and your body by these drugs, is non-compliance really rebellion? Or is it a desperate attempt to feel human again?
It's a rational calculation, and it's one that requires immense empathy from the doctor.
That's it for this deep dive into the electrical storm of epilepsy. Thanks for writing it out with us.